Talking to Dr. Howerton and Dr. Briley, and they're giving us some information about the American Society of Colon and Rectal Surgery. And of course, Dr. Howerton, before we ended this program for our first commercial, Dr. Briley was giving us some information about hemorrhoids. And what we'd like to do is to sort of continue that line of thought, which is to say that let's look at some of the diseases that generally you and Dr. Briley have to work with, and give our audience some information, some definitions, and some symptoms, and all of those things that you have in reference to some of these diseases.
Okay. I think, again, to talk about hemorrhoids, we have the point Dr. Briley made is write down what we need to talk about, and that is don't confuse a symptom that is thought to be hemorrhoids with hemorrhoids. She's exactly right. The type of patient I see that comes in is almost always complaining of hemorrhoids, and they may have something totally different. It could be a rectal cancer and so forth. So that's number one. There are different types of hemorrhoids that are treatable in different ways. Don't expect that just because you go to your doctor with hemorrhoids that you're going to have an operation. And everyone knows the horror stories that everyone hears about a hemorrhoidectomy and how terrible it is and so forth. Some people do very well and don't have any problems at all with the hemorrhoidectomy. And many people don't need hemorrhoidectomy at all. They can be treated by, the hemorrhoids can be treated by banding on internal hemorrhoids, which are hemorrhoids up inside the rectum. There are other methods of treatment as well as surgical. So don't be too scared to come to the physician simply because I've got hemorrhoids, I'm going to have an operation. That may not be the case. It could be something totally different. There are anal fissures, there are anal fistulas. And each of these is treated differently. And
now, what is an anal fissure?
An anal fissure is simply a tear in the lining of the anus, usually associated with trauma from a hard, constipated stool, that sort of thing. And most of those will get better on their own. Some require some medical treatment, and there is a surgical treatment for anal fissure disease as well. But again, the key that our audience should remember is don't expect you're going to get an operation because you have a problem. Many of these things are handled medically, and we would encourage people to see their physicians when they have symptoms because of the complexity of the problem. It's not always as simple or as obvious as it may seem.
Dr. Briley, I think you said that there was some information that you wanted to give us in reference to cancer. If we could, let's follow that up.
When a patient comes to see us with rectal bleeding, thinking it might be hemorrhoids or it might be cancer, I found a surprising number of patients who say right away, I don't want a colostomy. Now, a colostomy is an operation that many people fear. Basically, that means bringing the intestine out to the abdominal wall and wearing a plastic appliance to collect the stool or feces. And a lot of people don't get their rectal bleeding or their change in bowel habits or weight loss checked because they fear that one operation. And I'd like the public to know that we have many treatments for rectal cancer as well as colon cancer that do not involve a colostomy. A lot of people don't know that, but they need to know that, and they need to get those symptoms checked.
We've heard of something that is called Crohn's disease. Is that the correct pronunciation of that, Doctor?
Crohn's?
Crohn's disease. Now, exactly what is Crohn's disease? And give us...
Crohn's is a type of inflammatory bowel disease. It's an inflammation of the bowel wall. Crohn's disease extends from the mouth, can extend from the mouth to the anus. Anywhere in the bowel can be affected with Crohn's disease. That's in comparison to, or can be compared to, ulcerative colitis, which is also an inflammatory bowel disease, but is usually, or is confined to just the colon. Crohn's disease, the surgical treatment is primarily for complications of that problem, of that inflammation of the lining, where ulcerative colitis is actually treatable and can be cured with surgery by removing the colon. And there is a special operation that we do, again, going back to what Dr. Briley said, where we preserve the anus and the necessity for a stoma, a colostomy or ileostomy is not required for the appliance and that sort of thing. But the primary treatment of inflammatory bowel disease, both ulcerative colitis and Crohn's disease, is medical again, with different drugs such as steroids and inflammatory suppressant drugs and so forth.
And I would imagine, speaking to the two of you, that these diseases present irrespective of persons, which is to say that they're young, they're old, but let's talk about that in terms of when we look at these diseases. I think that many people often think of these diseases as being something that will accompany age. But now let's look at the impact that these diseases might have on the young, and from that perspective, I think.
Inflammatory bowel disease certainly can affect teenagers. I've seen patients as young as 10 years old who first developed ulcerative colitis. There is a second peak in the 7th decade of life of inflammatory bowel disease, but most times it does occur in the younger person. Colon cancer, again, is a disease of older people, but it can occur in younger people. I've seen a patient as young as 28 years old with rectal cancer.
And so there's no age limit. It will strike anywhere. Well, what about, I think we've also talked about, generally when we talk about these topics, and especially on a show like this, we talk about the impact that various diseases have upon minorities. And I think that when we talk about cardiovascular diseases and AIDS and et cetera, many of these diseases do have a tremendous impact upon children, minorities, and women. They have an impact upon the entire population. But do you find that there is any kind of impact that you could give our audience this morning that some groups might be susceptible? Has diet got anything to do with why people might have some problems dealing with? Let's talk about that kind of information.
Okay. From a minority standpoint, there's no real predilection for any particular race. There is some tendency, depending on where you live. For instance, urban populations have a higher rate of colon cancer, rectal cancer than suburban or rural areas. There is evidence to support that people that immigrate to different areas, like say Japanese who immigrate from Japan to the United States, they lose their increased risk for gastric cancer, which is higher in Japan, but they gain an increased risk of colon cancer when they get to the United States. So it's probably, in many cases, more an environmental thing than it is genetic. There are a number of groups of people who have genetic predispositions for colon cancer, however. Those are, however, not related to race particularly, but to other things.
Very good. And of course, we've got a few seconds before we have our second commercial break for the morning, and after which, when we come back, we're going to talk about what the public can do. And we'll be back with you following this commercial break.